non-functioning neuroendocrine tumor, like gastrinoma, glucagonoma, somatostatinoma, vipoma, and also non-functioning neuroendocrine tumors. Regarding TNM staging, I will pass by it rapidly. It is looks similar to staging of pancreatic adenocarcinoma, but I should stress that in T3 tumors are tumors larger than 4 centimeters, or tumors invading the duodenum or common bile duct, and T4 tumors are tumors invading adjacent organs like the stomach, spleen, colon, adrenal gland, or the wall of large vessels, especially the large arteries, celiac axis, or the superior mesenteric artery. This is a nice video about neuroendocrine tumor in the pancreatic neck at the venous confluence of the superior mesenteric vein, portal vein, and splenic vein. We are now scanning from the stomach, and this is the splenic artery. This tumor, neuroendocrine tumor, is very well localized, and we notice here that it's a very clean, very clear, very sharp line of interface between the tumor and the venous confluence. So it is not involving any vascular structure, and it is slightly more than 2 centimeters. So it is T2 neuroendocrine tumor in the pancreatic neck and body, and it is resectable tumor. This is opposite to this rather large tumor located also in the pancreatic body, and here we see that the tumor is encasing, nearly encasing here the tumor tissue and here the tumor tissue, so it is nearly encasing the superior mesenteric artery. So it is a T4 tumor, unresectable, just for chemotherapy. So very clearly that endoscopic ultrasound has a great accuracy in staging of neuroendocrine tumor. And during EUS examination, we can do tissue sampling, which is very important to differentiate NET from other benign lesions as focal pancreatitis or malignant tumors as pancreatic duct adenocarcinoma or SPEN, solid pseudopapillary epithelial neoplasm. Sometimes it is very difficult to differentiate. At this time, we should do sampling for immune staining. And it is also very important for proper pathological staging for further management. It is preferred to do fine needle biopsy in cases of neuroendocrine tumor, not fine needle aspiration, to obtain enough sample for possible immune staining, especially for chromogranin and synaptophysin, and also determining the mitotic figures and the Ki67 for proper WHO pathological classification. This is here a neuroendocrine tumor. It is insulinoma actually at the venous confluence, as seen from the stomach. Really, it is very easy to sample it by FNA or FNB as other pancreatic tumors, and we should do at least 2 passes and doing fanning, changing the plane of sampling to obtain enough tissue for immune staining. This is the WHO classification. This is the old one in 2010, but this is the recent one in 2017 and 2019. It classifies it into well-differentiated neuroendocrine tumor, which is subclassified into grade 1, G1, grade 2, G2, and G3. This is G3 is newly introduced. All these subclasses is well differentiated, and there is a poorly differentiated neuroendocrine carcinoma, not neuroendocrine tumor. This is much more aggressive, and it divides into small cell type and large cell type, and also the third subclass is mixed neuroendocrine and non-neuroendocrine neoplasm. This is the general algorithm for management of neuroendocrine tumor. If it is non-functioning neuroendocrine tumor and more than 2 centimeters, then he should go for surgery. If it is functioning, like insulinoma, gastrinoma, or somatostatinoma, it should be surgically removed regardless its size. Even few millimeter insulinoma should be managed. Now, recently in 2023, G1 grade 1 net less than 1 centimeter is justified for follow-up. This is the new suggestions in the algorithm. And EUS radiofrequency ablation is justified in G1 net between 1 and 2 centimeter. But surgery is preferred in G2 net between 1 and 2 centimeter because it is noticed that GT tumors has a higher incidence of recurrence after radiofrequency ablation. So it is better to apply radiofrequency ablation in G1 and not G2, but still it can apply it in both. This is an important the importance of determining the WHO histopathological classification of neuroendocrine tumor. Now coming to the very interesting and the very promising advances in interventional endoscopic ultrasound, which is tattooing of small focal lesions before the planned surgical treatment, fiducial markers placement, and the most important, which I'd like to talk in more details, which endoscopic ultrasound radiofrequency ablation. And the endoscopic ultrasound guided ethanol ablation is now obsolete or not recommended. It is rather effective, but has many side effects of injecting pure alcohol if it is spread to nearby pancreatic duct and inducing severe pancreatitis. Let us have a small talk about EUS guided preoperative tattooing. It is a technique in which carbon particle labels are injected into the pancreatic lesion via or under endoscopic ultrasound guidance. Sorry. These labels then serve as markers during laparoscopic distal pancreatectomy, which ultimately reduces operating time, cost, and amount of healthy pancreas that is recorded. This is our case report in the gastrointestinal endoscopy in 2021. This is a small tumor in the pancreatic head. It is deeply seated tumor and small, so it will not be apparent to the surgeon during laparoscopic surgery. So we must mark the level of this tumor. This is we inject in two sites. The site one is at the upper edge of the lesion, and site two in between the gastric wall and the upper aspect of the pancreas in the peritoneal reflection. And here during laparoscopic surgery, we notice that the markers are very, very clear. We do it by Indian ink or black eye. This is a mark, and this is at the pancreas, and this is a mark at the peritoneal reflection. So expected the tumor to be there. So we can have a proper safety margin, not too much to preserve the pancreatic tissue, and of course, including the tumor in the resected segment. This is a very clear mark, and this after the resected segments with very clear Indian ink. This is important, especially in if the intraoperative sonography is not available. Now, the most part and the last part of my talk is very important, which I talk about the promising EUS guided radiofrequency ablation. To know the magnitude of the problem, I'd like to share with you this video of a young man with recurrent severe hypoglycemia, sometimes necessitating hospital admission and IC admission. The recurrent hypoglycemic attacks left some mental defects, so it is a very serious problem here. The serum insulin is high, serum C-peptide is high, and here there is a very well localized tumor at the venous confluence of the superior mesenteric splenic and portal vein. Here we are scanning from the stomach. So the operation here is a major operation. It is either an extended Whipple operation, to involve this tumor in the neck of the pancreas, or extended distal pancreatectomy, or enucleation, which has a considerable side effect of leakage and pancreatic fistula. We all know that Whipple operation has a rather high mortality. Mortality is ranging from 5 to 10% in best centers, and the morbidity is up to 30%. Distal pancreatectomy having a leakage rate of up to 30%, and enucleation have an incidence of fistula formation up to 30%. So what I'd like to say is that sometimes we are obliged to do major surgery for a small, rather benign lesions like insulinoma. We are all know that insulinoma is almost always benign, having a benign behavior in up to 90% without lymph node or distant metastasis. Only 10% which can produce distant metastasis. So why doing major surgery for a small, rather benign lesion? In addition, patient may be poor surgical risk due to comorbidities, and patients sometimes refuse major surgery, so other modalities should be searched for. Why not radiofrequency ablation like that of the liver? The ideal ablation temperature is between 60 degrees centigrade and 100 degrees centigrade. This is the ideal temperature. Below 60, it is a sublethal dose. And above 100, there is charring. Charring is not desirable at all during radiofrequency ablation because it may induce a sticking of the needle to the surrounding tissue, and the tissues becomes very soft with more liable to complications. Then what is the rationale of EUS guided radiofrequency ablation in PNET? It can be applied to net smaller than 2 centimeter, especially if grade 1 of G1 as previously mentioned, and also in pancreatic net more than 2 centimeter in surgically unfit patients. It is very suitable for functioning neuroendocrine tumor, especially in selinoma. As I told you, in selinoma selinomas have benign behavior, and it has very low incidence of recurrence after radiofrequency ablation. The advantages of radiofrequency ablation is that it is a minimally invasive procedure, repeated treatment possible. In one of my patients, I did 3 sessions of radiofrequency ablation till complete cure, and there is short-term recovery. It is just 24 hours, or the patient can be charged in the same day. The adverse events is not common. It is less than 5% in the form of pancreatic duct stenosis, pancreatitis, pancreatic fistula, CBD stricture, or hematoma. We should mention one of the important studies in that field, which is the French multi-center studies by Marc Party and colleagues. Patients included are poor surgical risk patients, 30 patients, and including 12 patients with neuroendocrine tumors. 3 complications occurred. And interestingly enough, the first 2 complications occurred in the first 3 patients. 1 patient of pancreatitis with infected collection, 1 delayed small bowel perforation, and 1 pancreatic duct stenosis. So they changed the study protocol. They gave prophylactic non-steroidal anti-inflammatory like ERCP and antibiotic prophylaxis, and they avoid radiofrequency ablation close to the pancreatic duct. The success rate is 82%. It is convenient for the starting of the technique. And after 12 months, no recurrence occur in responding patients. This is a systematic review in 2021, including 35 case reports and case series describing 75 patients with insulinomas. 27 patients were treated with radiofrequency ablation, and 47 patients treated with ethanol ablation, and 1 patient received both techniques. The clinical success rate of EUS-guided ablation techniques was 89%. Surprisingly enough, it is a very high success rate, but the side effects was much more adverse events were much more with alcohol injection. So now we are restricting to EUS radio frequency ablation. Adverse events occurs in 15% of the patients, abdominal pain in 7 cases, 2 mild acute pancreatitis, 1 necrotizing acute pancreatitis, 1 local hematoma. However, unfortunately enough, all patients recovered and there were no peri-procedural deaths. I now like to share our experience in Egypt. We are now reached 10 cases of insulinoma. We did 10 radiofrequency ablation to 10 cases, 8 males and 3 females. 15 session with total of 36 passes was done, median of 3 passes for each patient. We used 19G cooling EUS needle. No major complications or mortality for mean follow-up period of 12 months. There is post-procedural epigastric pains in 2 cases of insulinoma, decreased gradually over the following 3 weeks, not necessitating hospital admission. There was complete clinical cure of 10 out of 11 patients, about 90% clinical success of cases with pancreatic insulinoma. However, 1 patient required 3 sessions, so we can repeat the maneuver several times, up to 3 sessions, and 2 patients required 2 sessions of radiofrequency ablation. The last patients, the failed patients showed partial response after 2 sessions of radiofrequency ablation with a slight decrease of the severity, duration, and number of attacks. Unfortunately, this patient was surgically unfit, so we are planning to do the 3rd session, hoping that it will be curable. This technique, which is moving shot technique, we may use in most cases. This is to introduce the radiofrequency needle to the most distal part of the tumor, then starting ablation, and then withdraw the needle a little bit, and the second ablation. So we can apply multiple ablations in the same pass and in the same session. Now I am coming to the final conclusion of my presentation, is that EUS is very important. EUS is very important in the diagnosis and staging of neuroendocrine tumors. Very important. It is the most sensitive modality, and the newly introduced radiofrequency ablation can be applied very nicely to non-functioning and functioning neuroendocrine tumor, especially insulinoma. It can be applied to tumors between 1 and 2 centimeters, and G1 tumor is better than G2. The complications are not common, and the success rate is about 90 to 100%. However, more multicentric randomized controlled trials are needed to verify its efficacy in management of neuroendocrine tumor. And thanks for your attention.
Sorry, you completely did not hear me. So thank you, Dr. Akasha, for your nice lecture and presentation. Can you hear me now? Dr. Akasha? Dr. Akasha? Can you unmute yourself? You went through mute again. Okay.
Yes,
Can
I
you
am
hear me
now
now?
hearing you very well.
Okay, sorry for that technical issue. So thank you for your presentation. And now one of the questions I have in the chat box is basically that neuroendocrine tumors are known to be hypervascularized and they have vessels running through them. Now, that being said, the question goes, do you think that using fine needle aspiration or fine needle biopsy would increase the risk of bleeding within the lesion, creating hematoma, or that's not a substantial risk? So please go.
Yeah, it's a very important question, really. Neuroendocrine tumor is very vascular tumor, exactly right. But in all cases, we can do FNB, FNA, and FNB in most cases. Sometimes about 10 to 20%, we notice that there is a small bleeding or a small hematoma in between the stomach or the duodenum and the pancreas. This is maybe maximum few centimeters, 5 to 10 centimeters. And a very important trick is to apply Doppler after taking the biopsy and notice what is known as patent tract sign. Patent tract sign is color flow Doppler signal along the track of the needle. It occurs in many cases, in up to 30 to 40% of cases, but don't panic, stay calm, and it will stop in 99% of cases after 2 to 3 minutes. If the patent tract sign persisted for 5 minutes, then this will be a serious situation. But fortunately enough, it occurs in less than 1% of cases. So the patent tract sign is common, but continuing for more than 4 to 5 minutes is very exceptional. It is stopped, fortunately enough, 99% stopped within few minutes and nothing occurred. And we noticed that in the multi-center study in 1991, there is one adverse event of hematoma, but hematoma out of 75. One hematoma in 75 cases, so it is less than 1%. But you are correctly, you are there. I noticed small hematomas and patent tract signs for 1 or 2 minutes, and then it stopped without any adverse events. Maybe some pains after the procedure, but it responded to usual analgesics, and all patients with these minor hematomas discharged safely in the same day.
Okay, so I'm just having a quick question. Sajjad actually raised an hand, so I will let him unmute for a second. But the question I have is that does that have any rule to play with the size of the needle or the application of suction or negative suction when you do the sampling?
Yes, shall I answer?
Yes, please go ahead.
Yes, my policy or my practice in doing suction or not. Many people prefer no stylet, no suction. Some people prefer low pressure technique or capillary technique. Some prefer high suction with 10 or 20 milliliter syringe. My practice is to apply Doppler first, whether the usual Doppler or low flow or power Doppler, and notice the vascularity of the lesion. Say if the lesion is hypervascular, so it is logically to start with no pressure or low pressure technique in a hypervascular lesion. This is the first pass. After that, I judge the first part by macroscopic on-site evaluation. If the specimen is not enough because I did no suction, then the second pass will be with high pressure. And the opposite, if the lesion is hypovascular, then logically I will start with high pressure technique. If the specimen is enough, that is okay. But if the specimen is bloody by high pressure technique, bloody specimen by macroscopic on-site evaluation, then I do no suction or low suction. So apply first Doppler, judge the tumor if it is hypervascular, then start with low pressure or no pressure. and judge the second pass according to the MOS of the first pass. And if the patient is hypovascular, start with high pressure technique and judge the second pass according to the MOS of the first part.
Okay, that's very valid point. I will now unmute Sajjad, Dr. Sajjad. Dr. Sajjad, if you can unmute yourself and go ahead with the question.
Great. Good morning from Manchester, and thank you very much for allowing me to answer the question. And I really enjoyed your talk, Imad, and as well as Professor Okasha's. So just a quick question. So small functioning neuroendocrine tumors, such as insulinoma, as the current guidelines suggest surgery. Now, with the efficacy and safety of EUS RFA treatment, do you think we will see a change in, hopefully, in the very near future, that EUS RFA offered upfront rather than surgery?
Thank you, dear Sajjad. Dr. Okasha, go ahead.
Yes, I'd welcome Dr. Sajjad. Very nice to see you over the Zoom. Very important question, and this is what is happening. It is not yet in the guideline, as you said, but I think soon, within less than 1 year or few years, it will included in the guidelines. Our practice in Egypt is now to apply radiofrequency ablation for insulinomas, especially insulinomas, and sometimes other functioning or non-functioning neuroendocrine tumors in tumors between 1 and 2 centimeters, and for surgically unfit patients with tumors more than 2 centimeters. What is surprisingly enough, and now surgeon is referring patients, even surgically fit patients. The surgeon is telling me why I subject the patient to major surgery, even if he is surgically fit, while I can do radiofrequency ablation safely, and very good response, especially in insulinoma, because it is a very benign tumor, and even no recurrence, very low incidence of recurrence. So I think sooner or later, within few years or 1 year, the radiofrequency ablation will be the first choice in cases of functioning neuroendocrine tumors, especially insulinoma.
Thank you, Dr. Okasha. We have another question from Dr. Ammar Atabi, our dearest friend at King Saud, Riyadh Hospital, King Khalid Hospital, sorry. Go ahead, Ammar.
Good morning, Imad and Prof. Thanks for the great talk. So a common question I'm sure that everyone is facing from the surgeon and the patient, the risk of tumor seeding. So for example, if you get a lesion that it's typical neuroendocrine and it's usually, or it's in a preferable location like body or tail, and simple straightforward surgery compared to the Whipple, would you still biopsy it or you just go straight for surgery?
Shall I answer?
Yeah, you go ahead. Go ahead.
Yes, go ahead, Dr. Ahmed.
No, you go first, and I will have, if I have any comment. Go ahead.
It is a very important question. The question is, do we need FNA, FNB in all patients with insulinoma or functioning neuroendocrine tumors? I do EUS, FNB or FNA if the lesion is not straightforward of being insulinoma. Sometimes there is a hazy nodule, bears the possibility of focal pancreatitis or something else. Then, as I mentioned, I should do FNA, FNB. The theory of seeding is not universal in the whole world. Many people do not believe in the theory of seeding. I think we should avoid FNA, FNB in tumors like hilar Klatskin tumor and something like that. But in distal tumors in the distal pancreas, and the patient will undergo surgery. Then the duodenum will be removed during the Whipple operation, pancreatic duodenectomy. So the track of the needle will be removed during surgery. So in my practice, I can do FNA, FNB of all lesions except hilar lesions from the stomach. So I'd like to know the experience of Dr. Ahmed. That is our experience.
Well, well said, Dr. Hussein. So basically, the risk is considered to be very low. Now, as we deal with all adenocarcinomas within the pancreas, unfortunately, whether this is metastatic or resectable disease, we may need to, unless if it's classically shown as to be malignant behaving, obstructive jaundice, straightforward lesion with no adjacent invasion to the vascular structures nearby, these patients are deemed to be resectable and without the need even to acquire any tissue. However, now the question is, if we do have the necessity and need to proceed with fine needle aspiration or tissue acquisition, whatever it is, now the needle, the conventional way of doing this, or previously we used to do the percutaneous CT-guided, ultrasound-guided, whatever you name it, which carries a higher risk of seeding given the long distance the needle travels that it takes the tissue. Now, that is almost less than 1 centimeter or less than 2 centimeter when you do it using the endoscopic ultrasound. And the recommendation, or the general recommendation, is if you have a lesion within the head of the pancreas, it is optimal and ideal to take the tissue through the duodenal wall, because that part of the intestine is taken out during the Whipple procedure, which will eliminate the risk of seeding and remaining tissue with the risk, though the risk is really low. Now, if the tissue is somewhere else in the pancreatic body or tail, then you have to do it through the gastric wall, but still we have a very low risk of feeding the tumor within the wall. That's how it's actually applied. So do we have any other questions? Or Dr. Akash, if you have any comment? We have the live case almost ready. So shortly we will be transmitting the live case, which will be a neuroendocrine tumor. Very interesting. So if no one has any more questions to go, we can proceed with the live case in less than 5 minutes. So I have actually some questions written from Suad. The question goes, Dr. Akasha, how many sessions do you usually perform, and do you have any recurrence rates? They were actually talking about, I believe, the radio frequency ablation management. So what's your overall approach, Dr. Akasha? How many sessions do you usually need to do for these lesions to be completely eliminated? And what's your actually standards or characteristics that you can determine or deem this patient has not had enough sessions?
Yes, it's a very important question. As I mentioned in my presentation, we did 11 cases of insulinoma. There is complete cure in 10 cases out of the 11 cases. In these 10 cases, one patient required 3 sessions. The first session and the second session was 1 month after the first one, and the third session is 1 month later. This is only one patient needed 3 sessions, and another 2 patients needed 2 sessions. Our practice is to apply the first session and follow up very importantly by the clinical, lab, and imaging. Clinical is the best one. After the procedure, the patients tell us that blood glucose level is very nice, no hypoglycemia, no feeling of fainting, no feeling of numbness, no feeling of disturbed level of consciousness. So the clinical response is very important. And the second is the lab response, serial assessment of glucose. And after 1 week, we assess the serum insulin, the fasting serum insulin and fasting serum C-peptide, and compare it to the pre-procedural level. The third one is to endoscopic ultrasound after or CT or MRI, but sometimes many of these lesions are missed by CT or MRI. So you can't follow by CT or MRI. We follow then by endoscopic ultrasound after 3 months. By this assessment, if the patient not improved or partially improved, then of course, logically, we will arrange for a second session. And if the second session produce a little effect, or for example, 30 to 40% relief of symptoms, and still the symptoms is compromising the patient life, then we go to the third session. So what I'd like to say, that first session, we do first session, and then have a clinical lab and imaging assessment, and then to determine whether we will go to the second session and third session or not. As I told you in my presentation, out of the 10 patients with complete cure, one of them needed 3 sessions, 2 of them needed 2 sessions. But
Okay.
sessions is different from the application. In the same session, we can do 2 or 3 passes in the same session with many applications. This is all called one session. But we needed a second and third session 1 month after the first one in 3 patients.
Okay, thank you, Dr. Akasha, for this very informative answers. Now we're going to proceed with our live case. I'm just going to give a little introduction about the case we have today. Is actually, she is a 20-year-old woman with no significant past medical history, initially presented to outside hospital with abdominal pain that is refractory to anti-acid medications, specifically PPIs, proton pump inhibitors. She underwent upper endoscopy over there that only revealed diffuse gastric erythema with few non-bleeding erosions. CT imaging also done over there with IV contrast showed 2 centimeter pancreatic head lesion concerning for possible underlying pancreatic tumor. Her labs on presentation, including CBC, liver enzymes, INR, urea, and metabolites, were all unremarkable. The patient was referred for endoscopic ultrasound evaluation. We gonna go ahead and present this case. I'm gonna leave the mic for a few minutes to proceed and jump into the case. Dr. Akasha, you'll be more than happy to proceed with the answers and questions. I will just move the screen to our audiovisual team right there.
Okay.
Stay tuned.
Best of luck.
Thank you. Okay, so let me this.
كمبيوتر لسه ما كمل.
Now, do you hear me? Here there is a question in the chat saying that non-functioning neuroendocrine tumor more than 2 centimeters, would you like to send to surgery? Yes, this is in the guidelines. Non-functioning neuroendocrine tumor more than 2 centimeters should be sent to surgery, should be removed because there is a high incidence of malignancy. So it should be sent to surgery if it is more than 2 centimeters. But in functioning neuroendocrine tumor like insulinoma or gastrinoma, it should be managed regardless its size, either by surgery or radiofrequency ablation. Even few millimeter insulinoma should be managed by surgery or radiofrequency ablation because it is very symptomatizing and interfering with the patient life activities.
والصفر انت كنت بتتصل على اثنين؟ لا ما المفروض بس يعني كنا هنا خلاص في سنة كده شغال ايه تعملنا
Now we are waiting for the interesting case of gastrinoma. It is not so common. In my life, I saw only 2 cases of gastrinoma, symptomatizing gastrinoma by Dullinger-Ellison syndrome. The very important anatomical site of the gastrinoma is what is known as Passaro triangle. It is a triangle in between the neck of the gallbladder, the upper lateral aspect of the pancreas, and the medial duodenal wall. So we should search for this triangle to search for gastrinoma. And sometimes gastrinoma not centralized on the pancreas, but it may be located between the upper aspect of the pancreas and the gastric wall. One of the 2 gastrinomas I have said is inducing slight bulge on the gastric antral wall, So gastrinoma triangle may be located in the upper lateral aspect of the pancreas, exophatic from the upper lateral aspect of the pancreas, or it may be between the pancreas and the duodenal bulb or gastric antral wall. So I am very interested to see the EUS examination of these patients with suggested gastrinoma. and seen also by CT scan. Here there is a question from the chat. Dr. Ahmed, he is asking how many EUS-RF radiofrequency ablation sessions would you offer before you can call it unresponsive? In my practice.
دكتور عكاش سامعني؟ السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
اوكي سوري والله كان عندنا شوية technical issues مع ال earbuds. Do you hear me loud and clear?
Yes, I am hearing you clear. Just I am hearing you very well. Just give me a few seconds to complete the answer
Sure.
of one of our colleagues in the chat. Maximum sessions in my practice and most of the practice worldwide is 3 sessions. After 3 sessions, if there is no response, then by then we should consider it as unresponsive. This is the maximum sessions. Most of the patients respond after 1 session, as I said to you, and 10 patients needs another session to be 2 sessions, and only 1 patient 3 sessions. But after 3 sessions, if the patient is not responding after 3 sessions, then I should consider it unresponsive patients, and we should search for another solution.
طيب, thank you so much, Dr. Hussein. Sorry for the delay. We had some technical issues. So, can you see me all?
Yes.
So we welcome you in our live case session. I would like to thank our anesthesia team, Dr. Ghabra, and our staff here, Mark, and our new star, Dr. Ibrahim Balbaid, actually one of the advanced endoscopists joining our team, as well as Dr. Sarah Al-Ghamdi, who wasn't around today for some commitments. I thank the Olympus team and Gulf Medical for joining us for this event. So as we mentioned, this is a 20-year-old woman with a suspicious lesion in the head of the pancreas presenting with abdominal pain and unremarkable labs. So we're going to proceed just to introduce our new star, released by Olympus Medical, which is the new ME3 endoscopic ultrasound device, replacing the ME2. As you can see, the major features we're going to see while we're doing the case itself, but there are some just technical features and changes in the keyboard that what used to be switches and roll of the mouse. The new machine has much more advanced features, all touch screen, which eliminates the risk of infection, easy cleaning, as well as less problems with the keyboard when it's being cleaned and disinfected. We're going to proceed with our linear scope as we are going to do tissue acquisition from this lesion. So Mark, please hand me the linear scope. Of course, for the general knowledge, we have 2 kinds of scopes mainly used, which are the radial 360 array and the linear, the 90 degrees array, on top of the front viewing EUS scope, which we don't have and we don't use regularly. But these linear scopes can actually have the ability to target and selectively pass needles for treatment and for diagnosis. So we're going to advance the scope. Patient is actually under general anesthesia, which I would recommend usually in these cases in general to avoid patient discomfort and to maximize the ability to evaluate the patient and cover all areas of evaluation. So while we're advancing the scope through the esophagus, we're going to go through major landmarks as we're going to see momentarily. And once I am in the esophagus, I like to switch to our EUS image. Please confirm, Dr. Akasha, that you're seeing the EUS image as well.
Yes, very nicely seen. I see you, and I see the EUS images very nice. Now the EUS images is now large and very clear. Thank you.
Excellent. So as we can see, I'm not going to really comment on the cardiac features, but actually we can see clearly here the heart being evaluated and nicely imaged, all chambers. Advancing this to just below the diaphragm, we're going to identify the major landmarks as we're going to see in a minute. So here is clearly we can visualize. I'm going to increase the gain so we can see it better. We can see the abdominal aorta going through, and this is the flow to confirm what we're seeing. As you could see, there is the nice flow there of the abdominal aorta, as well as we descend down just below the diaphragm. Followed by, or celiac trunk, followed by the superior mesenteric artery, which will be just a few centimeters below. Once that visualized, I'm just going to take, this is the power doubler. We're going to take the flow off. Not far away from that, you could see actually the adrenal gland. So once you have the celiac axis in level, you could see the adrenal gland and the kidney next to, this is the kidney. You could see the cortex. I'm just going to use the marker here to indicate what I'm seeing. Yeah, this is the pointer here. You could see this is the whole kidney with the pelvis in the middle, cortex in the adjacent view. And just on top of that, you could appreciate the presence of the left adrenal gland. In less than a minute, you could see it right there.
Dr. Ahmed,
yes,
Dr. Ahmed, can I have a comment?
Yes, please.
Thank you very much for visualizing the body and the tail of the pancreas. Although gastrinoma is very, 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 very rare to be located in the body or tail of the pancreas, it is almost always visualized from the prepyloric region and the bulb, but it is very important to examine the whole of the pancreas, because we all know that neuroendocrine tumors are multiple tumors. It is famous for multiplicity, and also IPMN and neuroendocrine tumors are commonly multiple. So in these two tumors, we should visualize the whole of the pancreas, because if they are multiple, one in the head and one of the tail, of course, the management will be totally different. So thank you for visualizing the body and the tail of the pancreas.
All right, so if I can ask the audiovisual team to eliminate switching the pictures when we are talking, just focus on the EUS image. So now, as Dr. Akasham thankfully mentioned, actually these lesions are commonly found at the head of the pancreas, but it's very important to scan the whole pancreas, including the tail and the body, especially if you don't know exactly where is the lesion. I mean, this one was ideally visualized on the CT imaging and identified. Now, in view, we have the pancreatic body as it travels all the way down to meet the spleen at the splenic hilum. I'm going to zoom in and choose the P mode to enhance the pancreatic duct. You can see in the middle right there, we can just in a second visualize it. I'm sorry. Right there. So that's the pancreas in the middle. You could see the small pancreatic duct right there. I'm just going to use the pointer to indicate it right there. You could see it right here. See that? That's the pancreatic duct. It looks nice and small and travels all the way down nicely, as shown here, to go to the neck. So I'm just going to remove the flow, freeze the image, and measure the duct. So the duct usually in the tail is about 1 millimeter, in the body is about 2 millimeter, and in the head is about 3 millimeters. And any larger than 3 millimeter size is considered abnormal. So we're going to set that, as you could appreciate, the duct is here. It's about 1.9 millimeters shown in the picture, and that's what we have. We're going to unfreeze. So as the duct travels, you could see the hepatic, it's the portal vein confluence once it's being joined right there. I'm gonna just, this is the portal vein right there. And it's made by the joining superior mesenteric vein with the splenic vein. You could see the two structures actually joining to form the portal vein. This is the portal vein right there. And this is the superior mesenteric vein, and this is the splenic vein. Once they join, they will actually form the portal vein, as you could see it traveling there. Not far from that, we could see also, I'm sorry, just if we can initiate the power, you could see the superior mesenteric artery traveling just below them and right there. All right, so I'm going to move for the sake of time to focus on the lesion. So that's basically the pancreatic duct and the pancreatic parenchyma within the body, tail, and neck. So nothing is being found. We're going to advance to visualize. In the prepyloric area, we could see the gallbladder, as you could see it there, right there. I'm not really appreciating any stones or any shadowing, any abnormality in the wall, thickening. Do you have any comment, Dr. Hussein?
Yes, yes, very nicely seen gallbladder from the antrum, prepyloric region. Very, very, very nicely seen.
Right there.
And this is exactly, Dr. Ahmed, the Passaro triangle. This is gastrinoma triangle in between the gallbladder, upper aspect of the pancreas, and the antral or duodenal wall. So expected to see lesions nearby the gallbladder, especially the gallbladder neck. It is especially the gallbladder neck. So you are very nicely visualizing the gallbladder from the prepyloric area. I think your complete examination. Yes, I noticed that the lesion starts to appear nearby the gallbladder. Yes, this is very well localized and very, 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 very impressive of neuroendocrine tumor. Do you agree with me? It is very well localized. And if you apply Doppler, it will be a vascular tumor. And here, contrast, EUS is very, very, very beneficial in diagnosing neuroendocrine tumors. Yes, very nicely seen that it is vascular, and you have a vessel in interfering at the needle pass. So, so
I know.
You will find some risk in doing FNA or FNB, as one of our respected audience said that it is a very vascular tumor, and sometimes there is minute or minor bleeding after the biopsy.
This is exactly what they say about be careful what you wish for. So we asked the question, we granted the answer. We have a very hypervascular lesion measuring about 23 millimeter, almost in the head of the pancreas and adjacent to the gallbladder structure. We could appreciate the big vessels traveling through, which is one of the classic features of neuroendocrine tumors. Also, another feature we could appreciate, Dr. Akasha, if you would agree with me, the smoothness of the wall, the boundaries,
yes.
the well-defined lesion that looks benign at the first glance. This is a very characteristic feature. Another thing that we have to say that 96% or more than 90% of these lesions are hypoechoic, and the remaining would be iso or hyperechoic. So most of the time they are hypoechoic, and this is the classic. You could compare actually that the lesion appears relatively darker compared to the adjacent structures. Well, you comment, Dr. Akash.
Yes, yes, exactly. Most of the functioning neuroendocrine tumor and even non-functioning neuroendocrine tumor are hypoechoic, hypervascular. Hypoechoic, hypervascular. I totally agree with you. Thank you for the very nice case. It is classic, having all characteristics of a neuroendocrine tumor, very well localized. The border is sharply demarcated. It is rather hypoechoic and hypervascular. So it is classic for functioning or even neuroendocrine tumors.
And you know what? One of the major things that we need to know when appreciate these lesions, are they actually invading adjacent structures? You could see that there is a small vascular structure traversing the field, and we'd like to understand or assess if this is actually arterial or venous. You could see running just beneath. I could see actually there is no interference. The plane is intact, and there's no possibility of any invasion of this abnormal looking lesion to the adjacent structures. And I can see as well, if you just give me 1 second, you could see actually the common bile duct just traveling next to the tissue, the mass itself without. So we could appreciate it, put it in the P mode. Maybe we can appreciate it even better. You could see that the common bile duct actually traveling right there. So I'm just going to use the pointer to indicate it. This is actually the common bile duct traveling close to the lesion without having any effect or impact by the lesion itself. This is the portal vein actually also being safe and sound with no obstruction or invasion. So I'm just going to measure the common bile duct right there, trying to have an assessment. Usually the common bile duct is no larger than 6 millimeter, especially in a patient that had the gallbladder in place. And we're going to freeze that. So the common bile duct here is about 3.9 millimeter, let's say 4 millimeter. Dr. Akash, any comment before? I'm just going to show them one more thing before we proceed with the contrast enhancement. We're going to apply the elastography. Ideally, it would appear harder than the adjacent tissue. So we're going to proceed with that. Dr. Akash?
Very nice presentation. Very nice presentation, Dr. Ahmed. Thank you. You demonstrated very nicely. And I think now you are scanning from the duodenal bulb near the superior duodenal angle. Right. I think so.
Yeah. So this is elastography being used. You could appreciate that the mass itself is actually low compared to the adjacent tissue, which indicates that the tissue itself is harder compared to the adjacent tissue. I'm just going to show you. This is very classic. You could appreciate how the tumor itself is so blue and purple compared to the red and green structures surrounding it. This is indicating this is taking a much more malignant behavior on a harder tissue. Dr. Akash, if you could comment on this elastography as well.
Yes, elastography is very nice, very sharp. It is very obvious that it is hard. It is mostly blue, and thanks to Olympus, the picture really is good. I did many studies in elastography in the pancreas, in the liver, lymph nodes, and this is one of the very nice images. What I notice here, and I should comment that all the lesions is blue, is homogeneously blue, except a very strip or a very elongated part of green. This may be beneficial, and if you intend to do FNA, FNB, then you should avoid the green part and in the center, and you should go in the upper aspect or the lower aspect in the blue part. This is one of the most important jobs or one of the most important benefits of tissue elastography. Do you agree with me?
I do agree, and actually I highlighted that area that you pointed out in this line. That's the path I would like to avoid because it appears less pathogenic compared to the adjacent structures.
The most important question, Dr. Ahmed, now, do you prefer to do FNA, FNB tissue acquisition or not? What do you think?
Okay, so for me, as we mentioned before, it's really important to determine what are we dealing with. This is technically a 2 millimeter lesion in the head of the pancreas that was actually found incidentally. Could be contributing to the abdominal pain, but it's not that big of a lesion that I would consider the abdominal pain is directly linked to it. But also, as I mentioned, though it is considered a neuroendocrine tumor, having a diagnosis of gastronoma is per se an indication for treatment, for resection or for ablation. The reason is they actually harbor a much higher risk of developing cancer in the future compared to insulinoma, even if they were non-functional. Gastronoma are considered aggressive, and by all means, if you found and diagnosed that kind of disease, take it out, even if it was small, even if it was asymptomatic. And therefore, I prefer to take the tissue acquisition for many reasons, including immune stains and histostains, because I need to know what I'm dealing with, number one. Number two is, as we mentioned, the mitotic figure, the rate, the Chi 67, all of these can help me understand how aggressive of a tissue I'm dealing with in this case. Dr. Okasha?
Yes, yes. The very respected opinion. I respect your opinion very much. But on the other hand, this is a tumor, mostly gastrinoma, by
Right.
biochemical and clinical settings, and it is larger than 2 centimeters. It is
Right.
larger than 2 centimeters. So according to the guidelines, it should
Should
go
be
for
taken.
surgery. It should go for
Absolutely.
surgery, except in two conditions. If the patient is surgically unfit, he is unable to undergo surgery due to comorbidities, or if after discussion of the patient, he is not willing to do major surgery. But here, the this is forward case of surgery because it is symptomatizing and it is more than 2 centimeters.
Okay.
But if the patient is refusing major surgery or he is surgically unfit, then we can try radiofrequency ablation. And also, gastrinoma, as you said, is more aggressive than insulinoma. So we prefer in gastrinoma to do surgery because after radiofrequency ablation, the recurrence rate, I think it will be a little bit higher than insulinoma.
Okay.
But the other opinion, if you don't take FNA, why to take FNA, FNB, and the patient at the last will send for surgery?
Right.
This is another aspect or another opinion. Your
Absolutely.
opinion is correct that
Yes.
sometimes in medicine we have to correct opinions, your opinions, and admire it too much. But if the lesion is between 1 and 2 centimeters, between 1 and 2 centimeters, then we have two options, either surgery or radiofrequency ablation. So here, FNA, FNB is important to determine the G stage, the histopathological classification. G1, so it is preferred to do radiofrequency, and G2, it is preferred surgery. This if the tumor is between 1 and 2 centimeters. But you told us that the tumor is more than 2 centimeters.
It's actually 2 centimeter.
2 point something.
2.6. No,
2.6.
it's 2. It's 2. 20.6 millimeters. So it's about 2.
It's about 2 exactly.
Yes.
It is as a
No,
verge.
I left you with no choice now.
Yes.
No, but you know what? Before we, I totally agree. I mean, this patient, as a matter of fact, I would prefer that since we determined there is no local invasion, there is no obstruction, the patient, she's young and healthy, and we are having the gastrin levels already checked, and they were 9,000. The gastrin serum level is 9,000. So this is diagnostic for gastrinoma. And as a matter of fact, I just want to proceed with our most important feature of neuroendocrine tumors when we use the contrast enhanced endoscopic ultrasound. So if Mark would show me the bottle that we used. So I don't know if you could see it from here, but we use Optisone. There is a SonoView but we don't use it here. Optisone is another contrast that we use to do the endoscopic ultrasound enhancement, contrast enhancement. And we're going to show you today how neuroendocrine tumors can show a specific feature. If you could refer again to the image is split in two, the regular EUS-B mode image and the contrast enhanced EUS image. You could appreciate that the tumor or the mass appears darker compared to the adjacent tissue. And by applying contrast intravenously, we would appreciate a change that I would love to share with you. So Mark, please go ahead and inject the contrast. Please pay a close attention to the image on the right. If it lights up or no. So Dr. Akasha, while we're waiting for the effect to happen.
Yes. The here contrast is very beneficial. It is very beneficial in hypervascular lesion as neuroendocrine tumor, and expecting that there is the dense contrast illumination of the lesion. When we see the right part of the screen, we will notice that it will take the contrast and becomes hyper echoic. Then
we are injecting right now. Okay. Oh my God! Look at that! Look at that! Look at that!
Yes,
That's
yes.
beautiful. That's
Very
very
nice.
classic. Yes.
Very classic. Yeah, this is a classic one. Yes.
So we are happy that we share something like this. This is very diagnostic for neuroendocrine tumors of the pancreas, and that's due to the hypervascularity nature and characteristics of these lesions. So when you inject the contrast, it will lit up like the stars in the night sky. So that's very beautiful. Dr. Ibrahim.
Would you expect that changes even with...
Can you hear Dr. Ibrahim clearly? You cannot. Dr. Ibrahim, why don't you jump on? Just put this and yeah. Dr. Ibrahim?
Yes, just a question for Professor. Would you expect this changes even with non-functional neuroendocrine tumor, like the contrast enhancement?
Do we hear anything?
Hello?
Can you hear us? Can you hear us? Dr. Akash, are you?
Yes, I am hearing you very well.
Okay, Dr. Ibrahim was asking a question.
Yes.
Hi, Dr. Okay, do you hear me? So I was just asking, would you expect this contrast enhancement even with non-functional neuroendocrine tumor as well?
Yeah, there is a question here from Dr.
Ibrahim?
Ammar.
No, Ibrahim Balbaid. He's asking if you would appreciate similar changes with contrast enhancement in non-functional tumors as well.
Yes, yes, yes. The hypervascularity is a common feature for functioning and non-functioning tumor. There is no difference in enhancement between functioning and non-functioning tumor. The enhancing is due to hypervascularity and not due to hormonal secretion. So all are hypervascular, whether functioning or non-functioning.
Perfect. So that will, because of the size, because of the nature of the lesion, most likely it's gastrinoma with the gastrin level more than 9,000. I think we do have a diagnosis right here, Dr. Akasha, didn't you think?
Yes, yes, it is classic diagnosis. So I am challenging now. Do you hear me? Now, do you hear me?
Yes, Dr. Akash, I hear you now clearly.
Yes, it is classic biochemical setting with high serum gastrin level, classic endoscopic ultrasound feature, very well localized, well demarcated borders, located exactly in the Passaro triangle in between the upper aspect of the pancreas, gallbladder, and duodenum, as seen from the duodenal bulb. It is somewhat echopoor, hypervascular, with contrast, classic contrast enhancement. So to me, it is a straightforward case of gastrinoma, very, very well demonstrated. Thank you, Dr. Ahmed. That is why I am challenging FNA, FNB. If the patient is surgically fit and will go to surgery, so I think we no need for FNA, FNB. It is not no other differential diagnosis. I think so. It is not cannot be mistaken for any other lesion. It is a classic gastrinoma. I think both are correct, doing or non doing FNA, FNB. What do you think?
You know, just like we haven't done any fine needle. I mean, for this lesion, obviously, I'm finding a very classic characteristic features of neuroendocrine tumors. Gastrin levels were more than 9,000. The patient had it in the pancreatic head. No evidence of invasion. I mean, honestly, I think this patient should go to surgery directly, even at the size of 2 millimeter. I really cannot defend me doing an FNA and FNB, even for the tiniest indication, risking that the patient may have a complication from the procedure, which will hinder her having the surgical resection.
Yes. I think both opinions are correct, but I am with not doing FNA, FNB because it is classic, straightforward case, should go to surgery. Even if the patient is surgically unfit or refusing surgery, we can do radiofrequency ablation. But here, the priority is for surgery because it is rather large tumor. It is about 2 centimeters, and the gastrinoma is rather more aggressive than insulinoma. So it is very safe to remove it surgically, totally by surgery. Radiofrequency ablation may ablate 90% of the tumor, and then the remaining 10% of the volume of the tumor may regrow again. So here it is ideal for surgery. No need for FNA, FNB. Except, as I told you, if the patient refusing major surgery or surgically unfit, then we may offer EUS guided radiofrequency ablation. Do you agree with me?
I totally agree. I'm just going to conclude with the last few things. Here we can see the tumor not invading any structures. Here we can see the common bile duct, and here we can see the pancreatic duct, all untouched by the tumor. And here next to that, we just see the portal vein. This is what we call the portal, sorry, the triad. The common bile duct, the pancreatic duct, and the portal vein. And here the tumor with a clear plane between all adjacent structures. Deliver the message and relay it to our dear surgeons if they are interested in knowing if this lesion is invading anything. I think it can go ahead and wishing the best for the patient. So
تفضل دكتور عماد.
No, I'm good.
Here Dr. Sajjad Mahmoud in the chat, and he is telling us that he's agree. No need for FNB.
Can we allow Dr. Sajjad to jump in, please?
Dr. Sajjad?
Can you unmute Dr. Sajjad? We would love to hear our dear colleagues.
Yes. He preferred not to do FNA or FNB, so he agree with us that it is a straightforward case, and FNA, FNB will not add to the very well characteristic EUS picture, elastography, and contrast enhanced CT. You did a great demonstration, to a classic case of the rare gastrinoma.
Dr. Sajjad, are you with us online?
Yes, great. Thank you very much. And again, fantastic live demonstration, Imad. Yeah, so I think young girl with very high gastrin levels, and you've seen a 2-centimeter lesion, which is sort of well demarcated, not invading any nearby structures. I think straight to surgery is the right option for her.
Thank you, Sajjad. Well, if we don't have any more questions, I think we conclude with this case.
There are two main. Dr.
Okay, go ahead.
Sorry, there are two main questions in the chat. One of the by Dr. Mahmoud Abdelrazek. Thank you, great demonstration. What type of surgery is best for these patients? I am not a surgeon, but I think here with very well localized demarcated tumor, I think is enucleation will not, at least not a major operation. I think enucleation will be sufficient, but sometimes during surgery, our surgeon changed their mind to do central pancreatectomy. Central pancreatectomy is to do resection from the right and left part of the tumor and leaving the distal and the proximal part of the pancreas, but it carries a higher risk of leakage. But these tumors are preserving, so try to preserve large volume of pancreatic tissue. So enucleation or central pancreatectomy, I think, will be less aggressive than Whipple operation. I think so.
I totally agree, and that's why it is sometimes important, Dr. Ukasha, that we determine if there is any relationship or direct. Okay. So, Dr. Akasha, we just want to refer that the question that was asked by Mahmoud Abdelrazek is actually coming from our dearest friend and expert, Dr. Abd Al-Lahabi. So we are very honored that Dr. Abd Al-Lahabi is joining us today in this case. So he actually the one asked this question. So I totally agree. Also committing in that, the surgeons, that's why when we have a neuroendocrine tumor, they would like to ask, do you have the pancreatic duct free or actually being involved within the lesion? The reason is they can do inoculation and save the patient big procedure doing a Whipple or something like that. So in this case, luckily the pancreatic duct is free as we have seen, as well as the common bile duct. So maybe she would have a less invasive procedure compared to Whipple.
Yeah, first, I would welcome my dear colleague and my dear brother, Dr. Abid Al-Lahibi, one of the best of the best. We have the pleasure and honor to share us this very nice conference and very nice meeting. Greeting to you, Dr. Abid, and to all colleagues in the lovely Saudi Arabia. Thank you very much for joining us.
Salam, Abid. Yes, yes. Abid is on.
Yeah, Assalamu alaikum, Ahmad, Dr. Ahmad, Dr. Akasha. First of all, I would like to thank you. Really, it was a very clear talk scientifically. And number two, very clear demonstrations of using EUS in such cases. Number three, it was a very good scientific discussion about the management and also the best for the patient. We are very happy to participate and to listen to the discussion. And usually this is the beauty of conducted such a meeting with my colleagues and our colleagues. And also thank you for Olympus for arranging such a gathering. Thank you. Just this is a few comments to I would like to share it.
Thank you, Abid. And I promise you all, hopefully in the next event, we will have a much bigger crowd. This event was actually a small one. And hopefully next time, Dr. Abid has the lead in the live endoscopy course that is being held in Riyadh. And if he may allows me, it will be held in March 2024. So you're all welcome to join. But hopefully these sessions will be much more regular, hopefully with Olympus sponsorship and support. One last thing I would like to show you, one of the amazing built-in features in ME3 is FibroScan. So the new feature of this device, which I find really a great addition to the hepatic EUS or hepatic endosonography, is the elastography. And you can see now I'm pointing to the left side of the left lobe of the liver. I'm just going to hit the measurements here, shear wave, and it's going to calculate it. And you can see here on the image on the left side, it shows you all the measurements which can determine if this patient is having fatty liver or not. So with this, I conclude, and I thank you all for joining us today. Dr. Ibrahim, if you could head. I just want to say a few thanks to the Olympus team. And if I may go back on the my PowerPoint. Okay, so if I can jump in again, sharing my PowerPoint. And okay, sorry. Yeah, there we go. Unmute. So yes, here I am. If I may share. Oh, thank you all for. Yes. You hear me twice. Okay, so let me just change this. Oh, I'm sorry. Oops, that's mine. Went in. Okay, so if I may do one thing here. Can you hear me?
Yes, I'm hearing you well.
So can you see me? That's the biggest thing. Can you show me? Can you show my picture, please? Audiovisual team, please. Switch to me. Okay, if I can. So okay. So I would like to thank. I'm gonna take the lead here as a host. Can you give me the host, please? Can you make me the host? Yep. All right. So first of all, I would like to thank all my team within our endoscopy suite, our fellows, our colleagues in intervention radiology, our surgeon, our oncologist, intervention radiology, pathology department. Really, it is the effort of every single person under this institution and the leadership, which is amazing, sponsoring and supporting us. And also, I would like to thank this great team. Look at them, all handsome people. From the left to the right, Mahmoud, Samir, and Walid. Walid could not join us today. He feels, I don't know, maybe he's doing something much more important. Samir never shows up to visit me. I hope someday he'll come and bring coffee or something, donut maybe, and shake it a little bit. And I really like to thank Olympus for the great effort that they did. It was an amazing effort by everyone, including. Can you see where's my picture? Where's my video? Can you see my camera? No? Okay. If you say so. All right, so I'm here. So I would like to thank you all for joining us today. I'm looking forward to see you really in new coming events. All my colleagues, all my friends, hopefully will join us in person, and hopefully we will make it as a multi-site activity with the support of our partners. Thank you so much, and I wish you a good day.
Thank you, Dr. Ahmed, for the nice gathering.
Dr. Akasha, anything you would like to say?
Yes. Finally, I'd like to thank you so much, Dr. Ahmed, for.
Dr. Akasha, you are on mute. You can.
Yes, do you hear me now?
Okay, I cannot hear you. I don't know why.
Okay, do you hear me now?
Yes.
Yes.
Oh no. Okay, I know why.
Then thank you, Dr. Ahmed, for the very nice gathering and very nice meeting, well organized, and thanks for your excellent demonstration of that very classic case. We see it once every 5 to 10 years. Then thank you very much, and thanks for Olympus that gathers us in this scientific meeting. And lastly, thanks for all our audience all over the world for sharing us our knowledge, and thanks for their dedicated questions in the chat. Thank you very much, and I'd like to thank all the audience for their interest in endoscopic ultrasound, and hoping to see you later. Thank you. Assalamu alaikum.
Assalamu alaikum. Welcome. Yes, and hopefully I will see you in different events. We will try to fit the time or change it to where everyone can join us, hopefully in later afternoon. I promise you that. Thank you for joining us. Thank you for everyone that jumped in and participated. See you later.